Welcome to this episode of the VJHemOnc podcast, which will focus on the evolving treatment landscape of multiple myeloma. With an expanding range of therapeutic options available across the disease course, treatment decisions in multiple myeloma are becoming increasingly complex. The question is no longer simply which treatment to give a patient at a particular point in their disease, but how treatment choices today might influence the options available later. From frontline treatment and the role of transplantation to the sequencing of CAR T-cell therapies and bispecific antibodies, clinicians must consider disease biology, prior treatment, toxicity, patient preferences, and practical factors when selecting the next line of therapy. In this podcast, we hear from experts on how these considerations are shaping treatment decisions and sequencing across the disease course. The Multiple Myeloma channel on VJHemOnc is supported with funding from AbbVie, Sanofi, Legend Biotech, and through an educational grant from the Alexion Pharma GmbH. These supporters have no influence over the production of the content. This podcast is intended for healthcare professionals only. With more effective therapies available in the frontline setting, decisions made at diagnosis may have important implications for treatment at relapse. To begin, Fredrik Schjesvold discusses the increasing importance of shared decision-making when selecting frontline treatment.
I think shared decisions are becoming more and more important. I think up to now we have very often had very clear ideas about what is the best treatment more or less for all. But I think the differences in pros and cons are increasing. I think one thing is frontline for the younger. Should you do a transplant or not? Transplant gives you a longer PFS. It does not give you a longer overall survival. It gives you several months of sort of not feeling very, very well. There's a very small sort of mortality surrounding that, but that's almost negligible. But the late line secondary malignancies you get from those doses of chemo is relevant. So for this, it's what the patient wants. Do they want to go through this? Is this more important with a longer PFS or to not have to do this procedure? In the elderly, those who are not transplanted, I think the question is more about how many drugs should they get. The best standard is a quadruplet, but for each drug you add, the more toxicity there is. So, and here there are several options. I think you can give the quadruplet with CD38 and VRD, which is the full treatment. You can skip dexamethasone. We have several trials now showing that that's probably not so important, and the toxicity for the elderly is quite big. You can consider whether to give with or without bortezomib, and maybe also use the high risk and the aggressiveness and the tumor load situation in the patient to discuss that. The treatment is better, but there's also neuropathy, so there's pros and cons there also. And then, of course, more options are coming, but those are the options that are most relevant today in frontline myeloma.
As patients move through the disease course, the treatment landscape becomes increasingly complex, and the emergence of novel therapies has introduced new questions about how best to use these approaches, both individually and in sequence. You will now hear as Peter Voorhees discusses the emerging approach to sequencing CAR T-cell therapies and bispecific antibodies, and the rationale for changing treatment targets.
There is some data on the use of bispecific antibodies after receipt of CAR T-cell therapy. Now, the caveat here is that data has been generated in patients who've relapsed many times over. But what we see is that if you change target, that seems to be a preferred pathway. In other words, if you get a BCMA targeted CAR T-cell therapy, the BCMA bispecific antibody subsequently doesn't perform so well. That said, talquetamab performs quite well after relapse from BCMA CAR T-cell therapy with a median progression-free survival of 13 months in heavily pretreated patients, which is just as good as those patients who have not gotten CAR T-cell therapy. So another nice space for, say, for example, talquetamab and daratumumab would be a patient who's relapsing after a BCMA-targeted CAR T-cell therapy.
With both BCMA and GPRC5D-directed therapies available, selecting the most appropriate approach at relapse may depend not only on previous treatment, but also on individual patient characteristics. Dr. Voorhees discusses factors that may influence the choice between BCMA-targeted and talquetamab-based GPRC5D-directed strategies.
So I think that the BCMA bispecific antibodies are very promising, and there are several that are already available around the world. We've got teclistamab, we have elranatamab, and we have linvoseltamab as well. And we now have 2 large phase III studies supporting the use of teclistamab with or without daratumumab in a similar patient population as the one that we just evaluated in the MonumenTAL-3 study. So interestingly, giving teclistamab in patients relapsing for their first time or beyond was superior to standard of care therapy. And the combination of teclistamab with daratumumab was also clearly superior to typical standard of care therapy, with both progression-free and overall survival advantages seen in both of these studies. So we've got teclistamab by itself with daratumumab, and now we've got talquetamab-based combinations coming onto the scene. They have distinct side effect profiles. So the BCMA bispecific antibodies have a high rate of higher grade infection. So if you have a patient who, whose disease course has been characterized by, multiple high grade infections, you might want to gravitate towards a talquetamab-based strategy. If you have a patient with severe lung disease, they may not tolerate a respiratory tract infection well, in which case a talquetamab-based strategy would probably be preferred. You need to have access to IVIG therapy if you're going to use a BCMA-targeted bispecific antibody. So if you live in a part of the world that does not have access to that resource, a talquetamab-based approach may be better for that particular patient. But the data with teclistamab by itself and with daratumumab look amazing. So if a patient's a good candidate for both, just given the unique side effects that we see with the talquetamab, a BCMA-targeted strategy may be preferred.
The potential of newer immunotherapy approaches to improve clinical outcomes is also important for patients with high-risk disease who remain a particularly challenging population to treat. Rahul Banerjee discusses updated findings from the MajesTEC-3 trial evaluating teclistamab plus daratumumab in patients with cytogenetic and functional high-risk disease.
So as all of you are well aware, the MajesTEC-3 published the results from the New England Journal of Medicine paper, but Dr. Costa and colleagues last December show that teclistamab plus daratumumab dramatically outperforms standard therapies in early relapsed myeloma, meaning in patients with 1 to 3 prior lines of treatment who are randomized to tecdara, meaning teclistamab, a BCMA bispecific antibody T-cell engager, plus daratumumab, the standard CD38 monoclonal antibody, versus conventional treatments. The tecdara arm had better PFS, so were in remission for longer, better overall survival, they lived longer, and better MRD negativity and quality of life. What we wanted to look at was the patients who have historically been left behind by these, innovations in relapsed myeloma are the ones with high risk anything. And those are the ones we really wanted to focus in on. Historically, almost every study talks about high risk cytogenetics, right? Patients with deletion 17p, 14, 16, et cetera, where historically they often have done worse in the setting of transplant. We looked at that, including GAIN1Q and AMP1Q, which are emerging features of high-risk cytogenetics in multiple myeloma. But I'm really excited about and why I really asked to lead this project. We also looked at functional high-risk myeloma. The whole point of all of our cytogenetic risk factors is to predict patients at risk of early relapse with standard treatments. Functional high risk is early relapse, meaning the patients who unexpectedly have a relapse much earlier than expected. With a triplet induction regimen that is defined as 18 months from start of treatment or transplant to relapse, or a quadruplet induction that's 36 months from start of treatment or transplant to relapse. And so historically, these patients have done terribly thereafter, right? A lot of studies, including ones that we've led, show that these patients often, their overall survival is only 2 years afterwards. After that first relapse, whatever is wrong with their disease biology keeps accelerating and they have more and more and more relapses. We need to break that cycle. And the question was, can MajesTEC-3 do the trick with tecdara? And short answer is absolutely, not just do the trick, but beyond surpass expectations. For patients with cytogenetic high-risk abnormalities, for example, again, the ones that we typically think about, but also the 1Q abnormalities, tecdara dramatically outperforms standard therapies. Again, hazard ratio in the 0.12 to 0.17 range, very similar to the overall hazard ratio for PFS from the whole study.
TecDara shouldn't just be for high-risk patients. On the other hand, I will highlight that of the patients with standard risk cytogenetics, so if you take all the normal high-risk features and gain1q, AMP1q, and take them out, everybody else, their 3-year PFS was 90%. So 3 years out, 90% of them are remaining on TecDara in remission, basically, functionally cured with a plateau on that curve, which is phenomenal. And moving to my personal passion projects, functional high-risk disease biology. Again, these are only the subgroup of patients in MajesTEC-3 who had one prior line of treatment and went on straight to the study, either TecDara or conventional investigator's choice, either DARA-PD or DARA-VD. Of the patients and I should add, the study was not powered for those patients at all. For the patients with functional high risk who went on to get DARA-PD, DARA-VD, 36-month PFS was 0%. Not a single patient made it 3 years without a relapse or death thereafter, highlighting historically how poor the prognosis has been for these patients. With the TecDara arm, that number was 77% at 3 years. Night and day, the difference. Same for MRD negativity. So not a single patient with functional high-risk disease biology who went on to get standard treatment the second line achieved MRD negative CRs. For the patients who got TecDara, the number was 33%. So basically, where do we take with this? TecDara, I would argue, is a great equalizer of relapsed myeloma. We know that some patients historically have been left behind by all the advances with PIs and IMiDs and all of that. TecDara is starting to close that gap. Indeed, of the patient with functional high-risk disease biology, the curves for the functional high-risk patients and the non-functional high-risk patients were both plateauing almost parallel to each other. TecDara is coming tantalizingly close to closing the gap for these patients. And I would argue that now, for some of the functional high-risk disease biology, they really should be preferentially getting CAR-T or TecDara at first relapse. But obviously, it's not just for the high-risk patients. The standard risk patients, again, 90% PFS at 3 years is phenomenal and speaks to how these regimens are setting us down a path that we've never seen before in myeloma, a path where people are probably on their way to a functional cure.
Alongside the emerging data with BCMA-directed approaches, increasing evidence is supporting the use of GPRC5D-directed therapy in relapsed or refractory myeloma. The Phase III MonumenTAL-3 study provides further evidence for talquetamab-based treatment, evaluating talquetamab in combination with daratumumab with or without pomalidomide. We will now hear Dr. Voorhees share updated findings from this trial.
We looked at the bispecific antibody talquetamab, which is currently approved for heavily pretreated patients, for myeloma patients who've relapsed just one or more times. So we looked at talquetamab in combination with the CD38 antibody daratumumab, with or without the immunomodulatory drug pomalidomide, and we compared those two experimental arms with a standard of care in the early relapse space, which is daratumumab with pomalidomide and dexamethasone. The primary endpoint of our study was progression-free survival. Secondary endpoints included response rate, depth of response, overall survival, and safety. And what we were able to show in this group of patients is that talquetamab with daratumumab, with or without pomalidomide, reduced the risk of disease progression or death in both of the arms, and to also reduce the risk of death from any cause. So we improved both progression-free and overall survival. And when we looked at the progression-free survival benefit across clinically relevant subgroups, we saw consistent benefit, including in older patients, patients who have ISS stage 3 disease, soft tissue plasmacytomas, high-risk cytogenetics, patients who've previously been exposed to daratumumab, consistent progression-free survival benefit. Now, with regards to side effects, we saw less infection with the talquetamab daratumumab arm compared to BCMA-targeted bispecific antibodies that are currently available. So, for example, the grade 3 and 4 infection signal with talquetamab and daratumumab was 29%, in contrast to 54% that we saw in the MajesTEC-3 study with daratumumab combined with teclistamab. We also saw less neutropenia in that particular scenario as well with the talquetamab and the daratumumab. But the target of talquetamab, GPRC5D, is expressed in select epithelial structures in the skin, as well as the nail beds, mouth, and to some extent, the inferior olivary nucleus of the cerebellum. which leads to a very distinct side effect profile of this particular agent. So we saw taste changes that in some instances led to weight loss, but in most cases not severe weight loss. We saw skin side effects that are manageable with topical steroid therapies. We saw nail changes. Importantly, the skin and nail changes that we saw were typically low to moderate in severity and rarely grade 3. We did see some signal of cerebellar side effects. So about 12.5% to 14.5% of patients had either ataxia or some form of balance disorder, but thankfully only 2.2 to 2.9% of patients had a grade 3 event. So I think on balance, when you look at the risk and the benefit and the notable progression-free and overall survival advantage, I think that supports, talquetamab and daratumumab with or without pomalidomide as a new standard of care for relapsed myeloma patients as early as first relapse.
While efficacy and choice of therapeutic target are key considerations when sequencing therapies, selecting between these treatments also requires their distinct toxicity profiles to be taken into account. Efstathios Kastritis highlights strategies for preventing and managing infections in patients with multiple myeloma, particularly those receiving bispecific antibody therapies.
Infections remain a major problem for all patients with multiple myeloma, starting from those who are newly diagnosed and even worse for patients who have relapsed disease or refractory disease and have been exposed to many different types of therapy. For newly diagnosed patients, there are guidelines suggesting that for those especially at higher risk, antibiotic prophylaxis, careful evaluation for the risk of infections, vaccinations, self-protective measures like masks or hand hygiene are very important. For patients at very high risk, and especially those with hypogammaglobulinemia, it seems that the use of immunoglobulin supplementation can significantly reduce the risk of infections. And this is more pronounced in patients treated with bispecific antibodies targeting BCMA, in which the implementation of preventive use of supplemental immunoglobulin seems to reduce the infection rate by 50 to 80%. So these are the main measures. It is also very important for the patients, their caregivers, and the physicians to recognize the infections and be very aggressive when they manage patients with a suspicion of infection.
Finally, as bispecific antibodies move into earlier lines of treatment and become an increasingly important part of the therapeutic landscape, questions are also emerging around how these agents can be delivered safely and effectively outside specialist centres. Mohamad Mohty discusses the transition towards community-based administration of bispecific antibodies and the infrastructure needed to support this approach.
It's truly a very exciting era for the multiple myeloma community and for multiple myeloma patients. Obviously, we have a lot of innovations coming into the field. Antibody-drug conjugates like belantamab are really moving forward. We have now the release of the data about the novel cell modes, especially mezigdomide in combination with carfilzomib and dexamethasone, the Successor 2 trial. But I would say one of the key highlights from this meeting, but also from the ASCO 2026 annual meeting, is about the increasing use of bispecific antibodies, namely the BCMA targeted T-cell engagers, which are now moving progressively from late relapse into earlier disease setting and earlier relapse. And obviously, the number of patients receiving these agents is going to increase. And of course, our goal is to make life easier to patients. And because these agents require regular administration, initially every week, every other week, then every month. So we have to figure this out. But also we know very well that there is a crucial initial step called the step-up dosing. And this is exactly where the efforts are going now in this direction to try to make it simpler, to make it smoother, more tolerable. And I'm very pleased and proud that I have collaborated and led a pan-European effort with more than 50 colleagues in order to design actually some easy to apply recommendations for the implementation of the use of bispecific antibodies in the outpatient setting, in the community setting, because we know innovation is important, but it's even more important to make it accessible to everybody and everywhere. And these guidelines were just published actually as an open access peer-reviewed paper in the e-journal of hematology. So you can find it easily on the web. And the summary about these guidelines can be divided into different pieces. First of all, it's about either the shared community share or completely in the community. Shared community care would be, for instance, you do your step-up dosing in the academic center, and then the patient is transferred into the local hospital. The full community care would be about having centers who are familiar with the use of these agents. So obviously, patient selection is a key issue. We have to make sure we're not dealing with patients who are very frail, patients who have too many comorbidities, patients who are unstable from an infectious point of view, from a hemodynamic point of view. The second important point is about educating the patient, but also the healthcare professionals about the key complications like CRS, like ICANS, but also most importantly, the management of opportunistic infection. And this is why obviously the guidelines strongly recommend to make sure that there are very strict, very clear SOPs when it comes to the monitoring, but also the management of these infections, but also we need to have collaboration, I would say, interactions between the academic center and these community hospitals to be ready actually to manage whatever difficult situation that may occur. And we believe this model is feasible. We already know from different real-world registries and studies that a substantial proportion of patients are now being treated in the community setting. And actually, the outcome is very reassuring, but it is obvious that we really need to stick to some very stringent guidelines and apply some strict rules, because efficacy is extremely important when it comes to managing a disease like myeloma, but safety is also very important, I would say even crucial. And please don't forget, the final outcome is about the combination of an excellent efficacy profile plus an excellent safety profile. And I'm very pleased how things are going these days.
As the treatment landscape in multiple myeloma continues to evolve, treatment selection and sequencing are becoming increasingly individualized. The expanding range of immunotherapies offers new opportunities to improve patient outcomes, but it also means clinicians must consider not only the most appropriate treatment in the present, but how each decision may influence options later. Factors including disease risk, previous treatment, therapeutic target, toxicity, infection risk, treatment delivery, patient characteristics and preferences will all play an increasingly important role in determining the optimal sequence for individual patients. Thank you for listening to this episode of the VJHemOnc podcast. For more expert insights into the latest developments in multiple myeloma, visit VJHemOnc.com. Don't forget to follow us on X at VJHemOnc to stay in the loop, and subscribe to our podcast on Spotify, Apple or Podbean so you never miss a new episode.